Sure. So I'm Sebastian King. I'm a paediatric colorectal surgeon at the Royal Children's in Melbourne. Have been here as a consultant for the last 3 or 4 years now. But started with my interest in colorectal conditions in children 15 years ago. I moved from Sydney to do a PhD here with my mentor, Professor John Hudson. And that was focusing on children with chronic constipation, not caused by Hirschsprung's disease, not caused by anorectal malformations. But that really sparked my interest and enthusiasm for looking after children with colorectal conditions. So after I'd finished my surgical training, I spent time in Columbus and in Cincinnati with Mark Levitt and Richard Wood and Alberto Pena, and then in Toronto at the Hospital for Sick Children with Jack Langer, working on building my experience in children born with congenital colorectal conditions. So I've been back at the kids, as I said, now for 3 or 4 years, and slowly building up the interest that I have, building the research background for these families and children, and that's obviously how we first met, looking at the quality of life outcomes for children born with anorectal malformations. What I've seen is that a lot of the families and particularly the children are severely affected, not only physically but sometimes mentally, by the process of being diagnosed with this condition and then living with this condition, having to come backwards and forwards into the hospital all the time. Yeah. And so with that in mind, I was really trying to get a much better idea of what the quality of life is like for these children and their families, so that we can better advocate for the support that they need. So we've made some big changes in the last 6-12 months, courtesy of the hospital, but also some of my fantastic colleagues that I work with. So we've now set up our multidisciplinary clinic, and that's with myself and my colorectal colleague Liz McLeod, but also with our urology colleagues, with our gynecology colleagues, of course, very importantly, our stomal therapy team, as well as the paediatricians, with a view to really having a multidisciplinary, holistic approach to these children and their families. So we meet regularly, we discuss the more complicated and complex of the kids, and then we see them. And hopefully by doing it that way, not only do we have a much better sense of what needs to be done and how we can manage these patients as a group, but also hopefully significantly reduce the number of times that the families need to come into the hospital, so that we can combine their clinic appointments so that they can see me or Liz, they can go and see the gynecology, they can go and see the urology team, and then they can also go and see our wonderful stomal therapy team. And with that in mind, to be able to not only look after them better, but particularly build a service that takes these children from the moment they're born through to when they're 18, and then being able to make sure that the transition of their care out into the adult service is as smooth as it possibly can be. Because we know that's a particularly tricky time for many children who've been at the hospital for a long period of time, how they transition into the adult care, so they don't get lost and don't feel like they've been abandoned. Sure. So anorectal malformations, as they're more commonly called now, is a very wide spectrum of conditions. The children are born more often than not without it being diagnosed. It's pretty uncommon for ARM to be diagnosed antenatally, so before the baby's born. And in that situation, it's either because the malformation is really complex, like a cloaca, or baby's got lots of other associated conditions, so their heart might not be right, their kidneys might not be formed properly, their spine might not be formed properly, and so the sonographer goes looking for some of those other associated anomalies and sometimes finds that the bottom isn't formed the way that it's supposed to. But as I said, the majority of children are diagnosed once they're born, and usually within the first 24, 48 hours of life. But because of the spectrum, it goes from babies that have got no bottom opening at all, so no anal opening, through to those that have a subtle change where there is an opening, but it might not be in the right place. And sometimes those babies are actually diagnosed months later. But the majority of kids, as I said, are diagnosed in that first 24, 48 hours of life. And the way the boys present and the way the girls present is very different. So the majority of the boys will have no opening, or if they do have an opening, it's small and in the wrong spot. Whereas the girls will often have an opening onto the skin, but it's in the wrong spot. And so it might be too close to the vagina, the back wall of the vagina, or it might be in the skin, but in further ahead than you would expect it to be. So the diagnosis is usually clinical from that point of view, and then the nurses and the doctors will go looking for the associated conditions that go with anorectal malformations. Once that diagnosis has been made, the majority of those children will then be transferred if they're not in a paediatric surgical centre. So they'll be transferred away from the parents, which is obviously very distressing, but sent to a referral centre where they can be assessed by the paediatric surgical team as well as the neonatal intensive care and special care team, so that they can then be looked after moving forward. Cloaca is one of the more complex types of anorectal malformations. It's seen in the girls, and it's where there's only one opening out onto the skin. So in the girl that's born with normal anatomy, there'll be the opening for the peeing tube, for the urethra, there'll be the opening for the vagina, and there'll be the opening for the anus. But in a girl born with a cloaca, there's only one opening, and the bladder, the vagina and the rectum have all come together as one and opened out via a single channel. These girls can be diagnosed antenatally sometimes, and that's often because the vagina fills up with urine, and you'll see that referred to as hydrocolpos. And sometimes when the babies are born, they actually need emergency surgery, not only to form the colostomy, to get the poo going out into the bag, but they sometimes also need to form a vaginostomy where they open up the vagina to allow the urine to drain, because it's draining preferentially into the vagina. These girls don't tend to have their surgery at the same stage as the kids born with other types of anorectal malformations. So often they'll need more imaging prior to their surgery, and they'll often have a delayed surgery, so maybe 6 to 9 months of age rather than 3 months or younger. And the reason for that is often to allow the babies to get a little bit more growth, logistically, to be able to bring all of the teams together, because at least in our service here at the Royal Children's, it involves the colorectal team, but also the urology team and the gynecology team, and working all very closely together as a unit. The girls with cloaca, therefore, long-term, have the potential to have more issues than the standard anorectal malformation. And so therefore the management not only of their bladder, but long-term their vagina and their genital tract, and then also their bowel and how they manage that, means that these young girls, young women, and then women who need long-term care often. And as we mentioned before about transition, this is the group that really needs to be carefully transitioned into adult care long term, so that they can have all of those aspects managed appropriately. Yeah. So you will have heard of Vactral. So Vactral is a collection of associated anomalies or malformations. Vactral is vertebral, so the V is for vertebral, well, it's the spine. A stands for anorectal. C is cardiac, heart. The TE, because of the American spelling, is tracheoesophageal, so that refers to kids that have esophageal or gullet problems. The R is renal or kidneys, and radial, as in the arm, and then L is limbs. And it's really a aid memoir to remind us to go looking for all of those things, because it's relatively uncommon for kids to have all of those aspects, though you do see it every so often. But probably between 10 and 50% of children with anorectal malformations will have associated anomalies. And so that means for the families who've got a new baby with an anorectal malformation, they might be a little bit concerned why they're having all of these tests done while they're sitting in the special care nursery or in the intensive care. But they're having cranial ultrasounds to make sure that their brain is fine. They're having renal ultrasounds, kidney ultrasounds to make sure the kidneys are both there and functioning the way they should be. They have spinal x-rays and sometimes spinal ultrasounds to make sure that the spinal cord itself is doing what it's supposed to and it's in the right place, and that the bones are formed the way they are. And sometimes they'll have an echo or a cardiac ultrasound as well to make sure that they have the heart formed the way it's supposed to. And that means for these children, they often end up with multiple anomalies, which means multiple appointments, sometimes multiple surgeries, usually in the setting of the complex cardiac disease that they might require extra surgeries. But it's something that means that we don't miss these conditions. Other things, there are other conditions that are associated with anorectal malformations, other syndromes such as Down syndrome, trisomy 21, and so we see particularly the anorectal malformation group within the trisomy 21 population, and so that's something that we look for, but that's usually pretty clear on clinical examination when the babies are born. And there's also a condition called Currarino syndrome, which is or Currarino triad, which runs in families often, is associated with anorectal malformations, is associated with a sacrum not forming the way it's supposed to, and often associated with a lesion or a growth that's near the rectum and near the sacrum, and so that's something that's important to screen for as well, particularly if there's a family history.
Yeah. With that, does it affect the reproductive system?
Yes, so often in girls there will be issues with the reproductive organs, and so girls with an anorectal malformation, the more severe the anorectal malformation, often the more severe the genital malformation. But even in girls where the bottom has been formed, it's just been formed in the wrong spot and on the skin, they can still have issues with the vagina, so a doubling of the vagina or a septum, a break within the vagina. Sometimes they can have a uterus that's split in two. And so these are all things that we need to be aware of. And we're much better now, I think, at screening for those associations. And so therefore, although the genital component is not part of the Vactral screen, certainly for the girls with an anorectal malformation, we think of that.
What about for the boys, like with their testes and this, etc.?
Yeah, so there are some of the boys will have associated genital issues, both hyperspadias, so that the penis isn't formed appropriately. Some of them do have undercentered testes, either one side or both sides, and so that's something that we go looking for. Longer term, they might have issues with their urinary system, so how well they pee. But also they might have issues with sexual function later on in life. We don't have a great handle on that. It hasn't been something that's been looked at in great depth, but hopefully as there's more awareness of anorectal malformations, there's better long-term follow-up, better questionnaires, then we'll be able to get a much better idea of what that's like for adolescent and boys and older and with young men. I can understand why parents want to know that. The majority of the time, there's no clear cause for a baby being born with anorectal malformation. If there's a family history, then there is an increased risk, but it's still a much smaller risk and it's much more likely that any children will not have an anorectal malformation. There's no obvious medication that's been given. There's no obvious cause in terms of foods or drinks or alcohol that predispose to the formation of an anorectal malformation. So unfortunately for many families, or for the majority of families, they're left with, why did this happen? We do know that it's more common in some populations than in others. So for example, in the Indian and Pakistani and Bangladeshi population, it's probably twice as common than it is in the Anglo-Saxon population. And why that is, we don't really know, but it certainly happens. And so a lot of the patients that I look after in Melbourne are of that background. But again, there's no clear cause why that's happened. We do know that if parents are what we call consanguineous, so if they are first cousins, that they do have an increased likelihood of having children born with congenital conditions, including anorectal malformations. And so a number of the families that I help, that is the case, where the parents are first cousins. But again, that's less common today and almost unheard of in some communities and some backgrounds. So the chances are very low if it's not Currarino triad. So if you've got a family history of Currarino triad, then there is a relatively high risk of having children with that condition. But if you're a new parent with a child with an anorectal malformation, then the likelihood of having further children with that is very low, particularly if the parents aren't related to one another, if they're not cousins. We would get genetics advice in some situations, but the likelihood, as I say, of that family having a second or a third child with an anorectal malformation is very low. What's their pathway?
Correct.
Yeah. So for the children who are going off to daycare who don't have an anorectal malformation, that can be quite a traumatic event anyway. All of a sudden they're using a toilet that they're not used to, they're toileting with others, and so for a child with an anorectal malformation, you can imagine that's got its own added anxiety, and particularly for the families as well. So, but I encourage the children that I look after and the parents to send their children and treat their children as per normal. And the reason for that is obviously the social interaction that the children get at the kinder or the playground is very important. But knowing that those families will have to give information to the carers at those centres. And so more often than not, the carers will be able to pick up on that reasonably quickly, because if they're changing nappies, then they will see potentially scars, particularly if their child's had a stoma. But if they've had their PSARP or their LARP, the majority of the time people won't be able to tell that unless they know what they're looking for. And so being able to explain to the carers at those centres that this child might take longer to do poos, or they might do small poos, or they might do regular poos that don't seem to have a time where they stop. So they're just aware of that. They also need to be aware of the fact that the children might be a little bit more anxious about their nappies being changed because of what's happened previously. But certainly I would encourage the parents to get their children, if that's what they want, to those childcare options. In terms of schooling is again one of those milestones, and it's not uncommon for 5-6-year-olds who start school to almost go backwards in their toileting, even if they've never had any surgery, never been born with an anorectal malformation. So again, being aware of that, and so I will counsel the families to let the school know, and also to make sure that the teachers are aware, so that if the child needs to go to the toilet, they can use the teacher's toilet, for example, so that it's cleaner, quieter, they're by themselves. You asked about sport. As an Australian, you should be playing sport all the time, and I would certainly encourage the children to get involved with sport as per usual. I've even got a number of children with stomas who are older for various reasons, who are competitive basketball players, competitive football players, competitive swimmers. And so there shouldn't be an impediment to them doing their school sport or their club sport because of their previous surgery or the condition that they have. I relatively regularly will be writing letters to each of those, the childcare or the schools. We're also lucky in that our stoma therapy team here are very regular visitors to schools and to kinders to be able to explain to the carers about particular individual patients. And I also say to the families that it's unlikely that in a smallish school that there'll be another child with an anorectal malformation. But there might be another child there who has chronic constipation who requires washouts, or has Hirschsprung's disease who's had a stoma previously, or has a form of spina bifida, for example, and they don't know about that because that family hasn't told anybody else. But it's not unusual for the teachers to then say, oh, that's fine, because we do have one other child here who has similar requirements, and we can manage those accordingly. So often in girls there will be issues with the reproductive organs, and so girls with an anorectal malformation, the more severe the anorectal malformation, often the more severe the genital malformation. But even in girls where the bottom has been formed, it's just been formed in the wrong spot and on the skin, they can still have issues with the vagina, so a doubling of the vagina or a septum, a break within the vagina. Sometimes they can have a uterus that's split in two. And so these are all things that we need to be aware of. And we're much better now, I think, at screening for those associations. And so therefore, although the genital component is not part of the vacral screen, certainly for the girls with an anorectal malformation, we think of that. Some of the boys will have associated genital issues, both hyperspadias, so that the penis isn't formed appropriately. Some of them do have undercentered testes, either one side or both sides, and so that's something that we go looking for. Longer term, they might have issues with their urinary system, so how well they pee, but also they might have issues with sexual function later on in life. We don't have a great handle on that. It hasn't been something that's been looked at in great depth, but hopefully as there's more awareness of anorectal malformations, there's better long-term follow-up, better questionnaires, then we'll be able to get a much better idea of what that's like for adolescent and boys and older and with young men. So Greg, again, with this, we need to get a sense of what their underlying type of ARM is, what their spine is like, what their sacrum's like. And so that way we can have a more informed discussion about the likelihood of being able to establish continence. And some kids will not be able to establish continence by themselves, but we can work with them towards pseudo-continence or social continence, where we can have them as clean as possible, and that's, really believe that every child, we should be striving for that. For the kids that have a more complex malformation with a sacrum that isn't formed properly and a spine that wasn't formed properly, then sometimes they just won't be able to establish that control. And so again, a bit like the children with constipation, there might be some children who will cope well and respond well to oral medications, be it laxatives, stimulants, etc. there'll be some children that doesn't do enough, or it just causes them to be more incontinent and run the whole time. Again, depending on the social situation, the psychology of the family and the child, what they've had done previously, where they live, some will use rectal therapy, so enemas, washouts, peristeen, as a way of being able to clear out the lower part of the bowel so that they're at least pseudo-continent for a period of time, be it 12 or 24 hours. And again, this is the situation in which families might opt for the formation of an appendicostomy or a cecostomy, because although the control might not be great at the lower end of the bowel, by having that washout, that antegrade washout, the Malone, it means that they're able to at least have some pseudo-continence with the child clean for 24 hours, hopefully, so that they can then endeavour to be in underpants rather than in pull-ups, and that they can then come home from, be it kinder or preschool or school, have their washout be clean the following day. But I say to the families that more often than not, the incontinence is more difficult to manage than the children that have constipation, and that the time frame to be able to establish at least some semblance of good control will be longer than those children that have got constipation as the primary issue. It's a very good question, Greg. I get asked it regularly, and I can only tell you that what I say, because there's no really good evidence or algorithm to be able to guide. But I expect that the children will toilet train a little later than they would have if they'd never had an anorectal malformation. And there are a number of factors that I explain to the families about that. They've had the malformation, they've been born with that, and again, depending on what type of associations they have, be it with the sacrum, with the spine, that will also influence their likelihood to be able to toilet train. But also they've had a period where they had a stoma, they had a period where they had the reconstruction, and they've then had the stoma closed. So even if everything has moved swiftly, it might be that they're 3 or 4 or 5 months already behind in terms of how long they've had their own process of stooling. So I say to the families that it's not uncommon for them for the babies or the kids to toilet train 6 to 12 months later than you would expect than the child who didn't have an anorectal malformation. And girls do tend to toilet train a little earlier than boys in general, in the general population. And so I would say to the girls with an anorectal malformation, if I expect that they are going to be able to toilet train, that 3 to 4 years of age. And for the boys, it might push out to 3.5 to 4.5 years of age. Now, sometimes they toilet train much earlier than that, but I make sure that the families take that pressure off. And I also make sure that the families let the child drive their own toileting, because there are a couple of things you can't make a 3-year-old do. You can't make them eat and you can't make them poo. And if you get into a situation where they don't want to poo, and they probably can subconsciously remember some of the things that have happened to them, in their infancy, then all of a sudden you have a situation of a child who doesn't want to go to the toilet, who becomes full and overloaded, and doesn't have the ability to deal with that in the way that other children do. Some of that discussion with the family is also reminding them that although their mother-in-law or their mother or their auntie or their best friend knows lots about toilet training, just to remind them that this child of theirs is different. And so therefore we need to work with this child and not other people's children.
Yeah.
I don't say to the families that we're going to fix them. What I say to the families is that we are going to do the absolute best that we can with what we've been given. And in some kids, that means that they are able to live a completely normal life. that nobody would ever know that they'd had surgery. And a large number of kids like that. But the more complicated the type of malformation, the more number of associated anomalies, it's less likely that they will have a normal bowel habit. And it might be that they require help with that for the rest of their lives. What I say to the families in that situation is if their child had diabetes, they wouldn't talk about when can we come off the insulin. And in the same way, I say to the families, if your child's got a complicated anorectal malformation, it might be that they need help with that for the rest of their life. And so trying to get them, both the patients and the parents, to recognise that we will do the best that we can with what we've got, and that there might be advances as we move forward, I hope there are, but that we will manage them so that they can be as normal in their bowel habits and their urinary habits as they possibly can be without necessarily being fixed.